a little bit about SWAY. SWAY stands for Supporting Wellness for Adolescents and Young Adults. And my name's Elaina Montague, and I'm the team leader of SWAY. That's the hat I'm wearing today.
Okay.
The title of assistant professor at Hofstra University, and I'm a senior psychologist at Northwell Health. I just also wanted to say, I think quickly that I really appreciate the work of NAMI. I used to run family-to-family groups for a couple of years in Nebraska. I'm also a family member of somebody with serious mental illness, so I think the mission of NAMI and the support that you all provide to people with lived experiences and also to families is really tremendous. There's also other team members representing different programs here, so maybe I'll pass the mic to some of my colleagues who are doing really awesome work. So maybe I'll pass it over to Dr. Frishberg, Nate here.
Okay.
Sure. Hi, nice to meet all of you. I'm Nate Frishberg, and I'm a psychologist at Northwell and also the team lead at the BOOST program, which stands for Better Outcomes Through Ongoing Specialized Treatment. We're kind of on the other end of early treatment. So our program works with folks who have had symptoms of psychosis for typically for greater than 2 years or are beyond the age mark for first episode treatment. And so, you know, folks kind of have graduated from the early treatment program or on track programs, or just no longer in those first 2 years since first experiencing symptoms, that's where we come in.
Okay. All right. So do you want me, let's see, we have Kristen here as well. Kristen, do you want to tell us a little bit about yourself? You are a professor of psychology and a practicing psychologist as well.
Yes, hi. Thank you so much for having me and all of us. My name's Kristen. I am a psychologist also at Northwell. I am a lead psychologist in the early treatment program in On Track, New York. I also supervise some people as well within our program. So trainees that are learning about working with young adults who are experiencing symptoms of psychosis. And I guess I'll save it because I know I'm going to talk a little bit more about what ETP is, which stands for the Early Treatment Program. But I can also introduce Kim, who we work very closely with over and On Track. So I'll be quiet.
It's wonderful. Kimberley, would you like to talk a little bit about what you've been doing?
Yes, hi. Hello, everyone. So my name is Kimberley. I'm a peer specialist at the On Track and ETP program. We can definitely delve more into what my specific role endorse or what I provide as services as we're continuing the conversation. But for now, I basically use my lived experience with mental illness or mental health diagnosis or mental health struggles in my journey to provide support to the participants that we service at the On Track and ETP programs.
Well, we're so happy you're here because we nurture our peers in NAMI, and you make a wonderful role model for them. So I'm really glad that you're part of this evening. All right, so Elaina, why don't we turn this over to you and we can get started?
Yeah, well, first off, thanks so much for having us to come and talk about these 3 different programs. You know, one of the things that I think makes Zucker Hillside Hospital really special is that we have this really beautiful continuum of care for people experiencing psychosis at different stages. And I really think of us as kind of a national leader in terms of this early psychosis care. So to talk a little bit about these different programs, we have a slide to help kind of ground the conversation. Is it okay if I pull that up, please?
Sure.
If you want to, I have it queued up here as well for you.
Oh, excellent. Even better. Thanks so much, Liz. Okay, so One of the special things about Zucker Hillside is that we've got these 3 different programs, as well as some really state-of-the-art research on early psychosis. One of the newer programs that we're going to talk about today that I'm representing is called SWAY. So SWAY stands for Supporting Wellness for Adolescents and Young Adults. And we're actually a prevention-focused program. So we are aiming to reach teens and young adults ages 12 to 25 who might be showing some signs or potential risk for psychosis, but haven't yet developed a psychotic disorder like schizophrenia. So you can imagine this might be a teenager who maybe the young person is recognizing or in the family that something's not right. They're starting to have challenges with school or work. They may be hearing or seeing things, but can recognize that that might be part of their own mind or part of their own thoughts. And the term that we use in research is to describe this population is clinical high risk psychosis. And so one of the amazing things about kind of Zucker is that we got this grant to start this young program Sway that's now about 3 years old and have been able to actually offer treatment services to these teens and young adults who are feeling distressed and they're scared about what's happening. And we get to come in and offer them a whole breadth of services. So we offer, like the other programs here, individual therapy. We offer medication management. We have a designated team member who helps with school and work goals. They're a supported employment and education specialist. We also are kind of unique in that we have a youth advisory council where the individuals who come into Sway can actually provide input and feedback on our program and say, hey, this isn't what we need from the team. And so we have this really cool youth advisory council. They meet over Discord, which is kind of a gaming platform of sorts, which I love that. That's something they decided to do. And they really kind of steer and guide our work. And then in terms of just some of our exclusionary criteria, usually individuals aren't the best fit if they have an IQ less than 70 or intellectual disability. Also an autism spectrum disorder, pervasive developmental disability. And I'll say that if these are kind of questionable, our team kind of errs on the side of wanting to be inclusive and if they're relatively mild problems, we will usually not weigh that heavily in terms of redirecting for other services maybe. And then, of course, because we're a prevention program, if somebody has a formal diagnosis of a schizophrenia spectrum disorder, they might be a better fit for some of these other programs that my colleagues here will talk about. And I think one of the things about Sway that I like to highlight is that we're really aiming to address these problems and the distress that's coming up before it becomes a crisis, right? Before somebody goes to the hospital, before a young person goes on to develop what we think of as schizophrenia. And there aren't that many of these programs in the US. There's only about 40. They've really grown since 2018. But it's really exciting to be able to do this work. And over the last 3 years, we've been able to help identify and work with roughly 40 plus people, which is, I think, really, really exciting. So if you have any questions for me, happy to talk about our team's work. We are really proud of the work that we do and feel very lucky to work with this fun and very much underserved population. But maybe I'll go ahead and pass it over to Kristen to talk about ETP.
Yes, sure. So again, I'm Kristen and I work in the early treatment program. And so we might be the place if someone maybe started off with Elaina and Sway and they were having maybe subclinical symptoms and possibly end up transitioning over to having a very clear first break, we would be that next place to help support them. So we work with young adults between the ages of 16 and 35 years old who've had their first experience of psychotic symptoms within the last 2 years. And our program is really focused on trying to translate decades of first episode psychosis research into real clinical practice. So we use targeted, developmentally appropriate interventions. We try to practice within a developmentally appropriate treatment setting. Kind of what that means is maybe we've got some jokes on our wall, we have some sayings, we try to keep it like young and fresh and someplace that feels not just like a doctor's office, but more of like a cool place maybe to go. Also, we work with a large multidisciplinary team. So we have licensed professionals and also very lucky to have our peer advocates. And we practice with really promoting engagement with the young adult population, as well as to really promote family involvement. You know, sometimes with this age group, with maybe a different diagnosis, the family, because it's a little bit older, the family might not be as involved, whereas we think it's very important, whatever the person identifies as someone close or a family member or someone that they can trust, to really get them involved in the treatment. We utilize a shared decision-making model with a focus on a recovery-oriented approach. When we think a little bit more about who might be a best fit for us, again, it's someone who's experienced any symptom of clear psychosis within the last 2 years. So that could mean someone maybe has been diagnosed with schizophrenia, possibly schizophreniform, schizoaffective, anything where the primary experience is a primary psychotic illness. Someone might not be the best fit for our program, same as like what Elaina was mentioning, some overlap there. If someone has an IQ of 70 or below, or an intellectual disability, on the autism spectrum, or have a pervasive developmental disorder, or if the psychosis seems to be secondary to something else. So really what seems to be more prominent is mood experiences, and the psychosis is related to that, substance, or anxiety, or any general medical condition that really seems to be primary. And let me see. Oh, and in terms of what we offer, again, a lot of overlap with what Elaina was talking about, but we offer individual therapy, group therapy, medication management and support. We even have some social groups, so some fun stuff instead of just talk therapy, but having people come and start to put a garden together, or a pizza and game night. We have a video game group. We have a book club, which I won't talk about. Kim will get into. And so a lot of fun stuff too. We also offer cognitive remediation to help with any organizational or memory difficulties or cognitive challenges that the person might be experiencing. When someone first comes to us, we like to provide a really thorough diagnostic evaluation and a neuropsych assessment, if that makes sense. And we also have people on the team dedicated to helping the young folks with any education or employment goals that they might have. And also we have a very nice peer support that exists. And so I'm going to turn it over to Kim at this point right now, so she can chat about that part of our program at ETP and On Track New York.
Thank you,
Thank you,
Kristen.
Kristen.
Oh. So as Kristen mentioned, our peer support services, we offer a lot of social groups. Myself and another peer that is part of the ETP program as well. We offer a lot of social groups and also one-on-one engagements as well. We can meet with the participants in the community. So there are times where I have met with someone at like Burger King just to get them comfortable with socializing, for example, or like a restaurant nearby or a park, to get them out of the house if they feel comfortable, if that's one of their goals, right? We also, some of the groups that I offer at the program include like anything that would interest someone's hobby or interest, like music group, I run a book club group with I co-facilitated with the other peer. And I think that those two, along with the video game groups, might be the most popular. We also allow them to attend a video movie night where we have a movie outing where we socialize with everyone. We might meet with everyone afterwards, after the movie, to discuss the movie. Just a lot of support around socialization. Um, as far as one-on-ones, like I mentioned, I've been able to meet people in the community. I meet with others on Zoom. We also, as peers, are able to service people through text messaging. So we have a work phone where we can text message or call some of the participants that are looking for a little extra support throughout the day. Or I had a participant that I worked with in the past where we body doubled. We also I would assist her sometimes in like, or the participant with struggles that they were facing while socializing at school. Just anytime in any sense of anxiety came up, for example, like she would text me and then we would engage, and then that would also help alleviate some of the struggles that she was facing throughout the day. So that's some of the services I've been able to provide in my position so thus far. um I'm trying to remember any if anything prevalent has ever come up in my role, but I think the biggest thing is fostering hope. I think in my role, myself and the other peer, we're able to foster some sense of hope. Because sometimes for a lot of the participants I've worked with, they've stated that their experiences feels almost like a mourning experience, like they're relearning themselves. And in that journey, it can be difficult. So having someone that they can see that has gone through something similar, if not the same, and is able to not just overcome it, but also strive for more daily, I think it really does foster a lot of hope for them to engage back into life and society with their friendships, with their family members. So that's pretty much the role. I'm open to any questions. And I think I'll pass it to Nate after this.
Thank you,
Thank
Kim.
you, Kimberly.
Sure. All right. So I'll jump in about Boost then. So Boost, as I mentioned, stands for Better Outcomes Through Ongoing Specialized Treatment. And, in the continuum that we offer of care for folks who have experienced symptoms of psychosis, I like to think of Boost as kind of that sort of final step. But the nice thing about Boost is that, unlike sort of other steps along the way, there's no sort of exit criterion. There's no time limit. So our primary aim is that we maintain the gains that folks achieve in ETP, or if they haven't come to us from ETP, whatever gains that they've made along the way, we're there to help them maintain those. And so typically folks graduate from ETP, after anywhere from 2 to 5 years, and they would come to us. And the reason you'll see that the sort of age limit that's listed there is 18 to 40. So I want to clarify something about that. So that's at the time of enrollment. People can stay with us well beyond 40. That's not an age out limit. It's just the reason we set it up like that is because you'll see that the ETP age limit is 18 to 35. So if folks are in ETP for a few years and they're still pre-40, they can still very easily transition to Boost. A lot of the things that sort of make the ETP model great are things that we've kept in Boost. So Boost developed about 5.5 years ago, and really was sort of modeled off of how do we, in a general clinic setting, recreate some of the factors that helped people get and stay well. And so we also operate with a shared decision-making, recovery-oriented approach. We really involve folks' families when they're open to that. One thing I would say is a little more of a focus in Boost as opposed to ETP is really increasing that kind of independent sort of management of your life, right? So we really sort of want to help folks kind of step into as they're, you know, in that emerging adult era, really taking ownership of the different aspects of their lives, including their treatment, but not limited to their treatment, right? Also kind of taking steps forward in their relationships, taking steps forward in living independently. Again, if these are goals of the person in treatment with us. So to that end, we have, as part of our program, a member of our team who's called a recovery advocate. And that member of the team functions in some similar roles to what Kim was describing, the roles of a peer, in terms of kind of the social aspects of that. So creating a social milieu for our participants. We have a weekly 2-hour just games and snacks and activities and opportunity for people to just drop in and hang out and connect with each other. Every week, we also have quarterly events. So we'll do we're currently planning our spring picnic. We do a fall outing to the Queens County Farm Museum every year. So these are really fun outings for our participants, and we also invite family members and loved ones to join those quarterly outings as well. And we, in addition to that, we run sort of what most people think of as kind of traditional treatment services. So we have medication management and psychiatry check-ins, even for folks who are not taking medications. We have individual therapy, and we have group therapy, groups that focus on sort of support and coping skills. We have a weekly group that is a bit more structured and learning sort of social and independent living skills. So that's a little more of sort of a structured education. Like we really sort of think of it more as a class. And, these are really all geared towards living a full and fulfilling life for our young people who are really kind of in that, more of our folks are sort of later 20s or early 30s on average. And so we're really kind of, our goal is to really help folks kind of take that next step in their life.
Okay. All right. Well, you've certainly given us a lot to think about, and I know there have to be questions because I have a lot of questions. And if it's okay, I'll start us off on the question period. Is that all right with everybody? It's okay. All right. Well, I'm very impressed with Zucker Hillside's patient experience work. I work on the Patient and Family Advisory Council with Sue Fitzgerald and a bunch of other people on staff. And Sue reports every month when we meet about patient experience, and the quality of the scores of the patient experience have gone up exponentially lately. But how does that translate with your younger population? Do you understand? I mean, do they do the same kind of survey that the other patients do about their experience and what they would like to have and how they are experiencing the process?
Yes. So, I mean, I guess what I can add to that, or what I can say about that is that, so we are, I think pretty much all Northwell programs use the Press Ganey patient satisfaction surveys. And we distribute those, in terms of kind of like at the program level. I think that the data typically are aggregated at a broader level, more so than at sort of specific program levels. Although I don't want to speak for every program. I'm not sure of the details on that, but I know that, we pass those surveys out. We used to do it, we used to have stacks of envelopes. Now we send a link, but
that's actually happening this week.
Yeah.
Also,
Okay.
specifically with like our on track program, which we, is really within our early treatment program, pretty much the main difference there is just the length of having a symptom, and that's for less 1 year or less. We have different forms that go out through On Track Central asking about how it's going with the providers and asking for feedback. So it's something that's not run specifically through Northwell, but separate through On Track to assess, again, how things are going and allow for opportunities for adjustment and change to make sure the treatment is really meeting the person where they are.
Great. I have other questions, but I will turn the floor over to anyone who has a question. Anybody?
I do.
John,
Oh, go ahead, Liz.
I see John, and then I'll look for hands.
Okay.
I-
A couple of questions, and I'll just throw them all out there at the same time. One is, where do most of the participants come from? Like, are they coming from, and do you kind of go out and look for folks, or people come to you? The other question is, what is the ethnic makeup of the majority of participants? And lastly, is there a number that you kind of cap at, for each one of the programs, or is it just unlimited? So you could deal with any of those.
Yeah, so happy to just talk a little bit about our configuration, how we look at that stuff for Sway. So in addition to all the other team member roles, and I think this is probably true for ETP on track and maybe even Boost, we have a team member that is called an outreach and recruitment coordinator, and her name is Nicole Germano. And basically that role is meant to go out into the communities to spread awareness about these services. She helped to coordinate this meeting, but couldn't be here today. Um, and also to try to reach people in various settings. So for Sway, our goal is prevention. So we actually want to try to get people before they have formal contact with the mental health system. So we do a lot of outreach to schools, middle schools, high schools, universities. We also try to target other community providers, of course, who may be working with these teens and young adults experiencing symptoms. I would say in terms of the majority of our referrals, we use a tracking system to kind of see where they're coming from. A lot of them come from within our other outpatient clinics at Zucker or um, from our Northwell school-based mental health programs. So Northwell also has this amazing program that's really led by Dr. Vera Foyer, and it's really offering school-based services within high schools on Long Island. So we've developed some successful partnerships with them, and had collaborations and a great number of referrals. And then our other referrals come from Northwell has a large number of pediatric behavioral health crisis centers on Long Island too. So maybe a family member has concerns, they bring their teen to one of these um, outpatient kind of crisis settings, and they think, oh, let's call Sway before we hospitalize them. And we really like to hear that, right? We want to catch people again before they have some kind of crisis. And the whole team also participates in different kind of outreach. This is an example of that to a non-provider audience, really, which is also important to us. Reaching different members in the community who still may have contact with youth. And then in terms of kind of the makeup of our enrollment, we try to be really thoughtful about that because we want the people that we serve to reflect the community. So we actually look at census data. So what does the census of Queens and Nassau County look like? And does that align with the expected census data? And we found that roughly we have a similar makeup, though we don't have any restrictions on where people live. So we do have some people from Brooklyn and even Westchester County that we serve. So it's a little hard to kind of factor that all in, but we see people from all types of backgrounds in our clinic. John, did I get all of those questions at
You
least?
absolutely did. You covered everything. I could go home now. No, I'm just kidding.
Okay,
I'm
I don't
home.
John
Nader.
did ask about all the programs, and I'm curious about that as well, because that's kind of been a frustration on my point when I refer people to the early treatment program, is that often they're turned away. So what are your numbers? Like, what do you guys cap at?
So the early treatment specifically doesn't have a cap at numbers. We don't filter based off of that criteria. Pretty much the criteria that will lead to us deciding whether or not a person is a good fit or not will be based more on age. So having to fit between that age range of 16 to 35. Symptoms of psychosis have to be within the last 2 years. So even if someone maybe didn't have symptoms for a long time, but when the person was 11 or 12 had very clear symptoms of psychosis, that would still unfortunately mean that it's outside of the 2-year mark, starting much before that. Obviously, I think, Nicole, who's not here, but I know set this up, does the outreach and recruitment and also the screening process. And so there's also a lot of attention paid to making sure that there's a very thorough assessment to make sure we're not missing anyone that we would be a good fit for. So the age, the symptoms being present no longer than the 2 years, and then the type of presentation. So it really having to be a primary psychotic illness, mostly because a lot of our treatments are very tailored towards that. So we would really be doing the person a disservice if, let's say, the primary experience that they're having is more related to mood, because we do a lot of like CBT for psychosis, and all of our psychiatrists obviously can have a lot of knowledge, but are specifically focused on working with those young folks with psychosis as well. In terms of on-track New York, that's a little bit different. That does have a cap, but that would not prevent from access or entry into the larger early treatment program.
Okay, what about Boost? Do you have any kind of limitations with how many people you can serve?
So no, there's no specific cap, and our anticipation is that because we don't have an exit criterion in terms of age, that it's likely that at least for some time our program is going to continue to grow, and so I think we're sort of working on building a team that expands with that growth. So yeah, there's no specific cap. The only time that there have been a couple times where we have had to close to new referrals simply because of staffing issues. So the only time that we're ever really limiting entry into the program is really just due to, do we have the staff to serve everybody? I think that the other answers are probably fairly similar, at least for where participants are coming from in terms of referral sources. So Boost is a little different, I would say, from Sway in that regard. Maybe a more overlap with ETP, but a lot of our referrals tend to come. I mean, for one, we get a lot of referrals from ETP, right? But that was sort of what we were built for, was for ETP to send us folks who are graduating. But aside from that, a lot of our folks are referred to us from other treatment programs. Usually there's some treatment touch point before they get to Boost. Because typically if they're coming sort of very fresh with no treatment exposure at all, more often they're likelier to be within that first 2 years and likelier to end up at Sway or ETP. So we get a lot of folks who are referred to us from like an inpatient hospitalization or from another outpatient program at Zucker or in the community.
So one of the criticisms of the early treatment program, not specific to Zucker, is that there's a finite amount of time, right? So in theory, it's 2 to 3 years. And to be honest with you, my son was part of one of the statistics. He was Dr. Birnbaum's, one of his first patients. And then you're done, and now you move on. but now you have another break where things are just maybe not good or whatever, or maybe minor issues, but you really can't go backwards. And I suppose Boost is that continuum of care that maybe wasn't there 6 years ago. I'm not really sure. But how do you speak to that, ETP and Boost, that how are you acknowledging that continuum of care? We're using that word very broadly, but how do you address that kind of criticism that 3 years, you're on your own?
Yeah. I think as a provider, I just want to validate and normalize that experience because I think I feel it on my end too. I think there are times when I notice sometimes the engagement can really take almost the year or 2 years to really start to feel like connected, and then it's all almost time about talking about moving on. So I just want to like validate, and I feel that too. And sometimes I'm like, I don't want to have this transition. I would say that a lot of the time we try to think of it in a way as like graduation or like moving on to the next step. And so the belief being that when someone is first having these experiences of a clear first break happening, that we are that like kind of all-encompassing, like supportive, treatment that's there that really needs to be much more intensive because there's so much changing in that young person's life and also in that person's family's life too. It's not just the young person that it impacts, right? And so there's a hope that there's a really intensive treatment and support, and that we hopefully pull that person along in their recovery of starting to really get to feeling well, getting on their journey of really living a life of value, of what is of value to them, and that we are transitioning to this next level of care because that intensity might not really match what the person needs any longer. I think that we try to be very thoughtful of not pushing it before it makes sense. So for example, I have some people that I've been working with now at this point, maybe 4 years, which is going over the time, but it just didn't seem appropriate yet. And so we also try to be very individualized of making sure that it never always feels like maybe right, but what actually maybe matches that person in their growth and trajectory of their treatment with us. But I'll stop because I know some other people will have some great things to add to that as well.
I have another question, but it's kind of the flip side of Liz's question. You are all encompassing, and I think that kind of support is wonderful. Do you have any statistics on how on your recovery rate and cure rate compared to non-ET early treatment program patients?
I can say that we're looking at some of that at least for Sway, but I can say that one of the kind of cool things about Zucker, and I also do want to speak to Liz's experience too. So I just want to bookmark that, is that a lot of these programs like On Track, ETP, now more recently Boost, and then Sway, um, they were a part of, we have a very large research institute that's very robust here that's also looked at outcomes. And some of the first research that was on these types of treatment teams for early psychosis, which is what we call coordinated specialty care, which is on Track's model. Um, some of that first research was done at Zucker Hillside Hospital, and those were part of what we call the RAISE clinical trials. And the RAISE studies were really fundamental, and they're not that long ago. I think they started in the early 2000s and the mid 2000s. And really they were some of the first studies that were done to show that one, recovery is possible. Early intervention does make a difference. But as we know for all of these programs, and we also know this from some of the On Track youth and family councils that are a part of the entire statewide network, that that's not true for everybody. Like some people need more help, right? I think we're all unique and different. But I don't have any hard numbers comparatively. ready with us, but there are some papers that we can share as resources. Some of the trials were done with John Keane, who was a researcher or is a researcher at our institution. And also Lisa Dixon, who I worked with previously as part of OnTrack's network at New York State Psychiatric Institute. But I think that it's an ongoing thing. Like we see improvements, but there are also things that we're learning today about what are also the shortcomings, like long-term outcomes, or, I know this true from my family's experience of COVID, right? And watching my loved ones' progress go backwards. And so I think that one of the important things is that research needs to continue to happen. Um, as well as getting feedback from families and people who have been through the program even 10 years later. Um, I think that that's where we really are learning about the gaps between research and practice. And I will say that I know that actually the OnTrack's statewide councils have brought up the issues around discharge and time of program completion because of similar experiences to you, and they're trying to problem solve different issues and pilot new initiatives. And one of them, I'm actually sad she's not here today. Hillary Burdish, another team member of ours, is also piloting another kind of step down program from services called LIFT, which is Living Well for Tomorrow. So these things are evolving, and trying to respond to what we're learning from advocates, really, like families like you.
What I was hoping to hear is that these results, the cure, recovery, it seems to me what you're doing is what everyone should be doing, and I wondered if more hospitals will do what you're doing, because one of the things we learn in family to family is that it can take up to 11 years, that's the average for getting the proper treatment and the proper care for a person with mental illness. And now with the complications of COVID and everything else going on, we need to make sure that that doesn't continue to be a statistic. And by doing what you're doing, by the all-encompassing, all-supportive, I think you're giving people a much better chance of getting the treatment they need before those years kick in.
One thing that we haven't discussed is medication. So the clear ambiguity is the best of intentions, the best of psychiatric care and therapy and coping and cognitive behavioral therapy is the trajectory of the illness, which is not linear, as you all know, and that the medication doesn't keep up with that trajectory. And so everybody here knows me well enough to know that the trajectory that Zucker didn't keep up with my child was leaving olanzapine and going to clozapine. And I am 1,000% a proponent of going to clozapine sooner because of the dopamine suppression and the lack of cognitive abilities. And I could talk forever about it. So that is really, and that's another one of the criticisms of the ETP programs is that they don't address problems with medication protocol within our health system, patients for clozapine and the administration of more complex medication regimens is a huge, huge conversation. I don't know what to say after that other than, I do have a question, entry point into this. So the 2 years, that just seems like, wow. 40 years old, you're going to have your first episode of psychosis. I just find that to be very an interesting thing, is that
so no, it happens quite rarely, but part of the reason that we sort of built those criteria for Boost in terms of kind of up to 40, right, was the idea that we would be having folks who are graduating from first episode programs and may have later onset at the time they start those programs. So if someone did happen to have a later onset, let's say, at 33, right, and they come to ETP a year later at 34 and they're still eligible, they're still within that first year, let's say, right, and then they go there and they're in treatment in ETP for a few years, we still want to be able to take them into Boost at that point and not turn anybody away. So what we do end up having is there's a every once in a while we have somebody who is past 35 but under 40 and does have relatively new onset of symptoms. It's rare but not impossible. And sometimes that happens, and we are still an option for folks. I mean, I think Liz, to your point about just some of the ways, some of the insufficiencies of our system, right? Some of the limitations. There are ways that people fall through the cracks, and I think one of those ways historically has been, okay, someone's still a young adult, still really just getting a handle on their symptoms for the first time, but maybe they've first experienced symptoms a little more than 2 years ago. And, I think for valid reasons, right, the way the ETP is structured is really at that, meant to sort of capture people in that very early phase. But then what happens for folks who have had 3 years of symptoms and haven't really connected or stayed connected to treatment? And that's one of the great things about the addition of Boost, is that now we have somewhere for folks to go. And the sort of purpose, kind of thinking about like, not all outcomes are the same. Not all outcomes are, okay, you get treatment in the first couple of years and then things are better and then you stay better, right? That's certainly the hope with many of our folks graduating from ETP, but there's inevitably ups and downs. And so Boost, whereas ETP is designed a little more for that intensive phase at the very early part of illness, Boost is, the goal is we're designed to be a little more scale up and down, right? To meet the needs of, okay, you can come and have 3 or 4 or 5 different kind of touch points in the same week, or you can come see us every 3 months and get, sort of check the box and get your refill on whatever medication or no medication, right? So it's really meant to be kind of scaled up and down. And that's a different program design from one that's really designed for that intensive early intervention. So to Kristen's point earlier about just kind of like, why is ETP structured the way it is with that time limit? I think often that time limit is not ideal, but in some ways it serves to keep ETP really well suited for the people at that very early stage.
I have one question. I'm sorry, Dave. I just wanted to
Unmute yourself.
ask. Oh, am I muted? No.
No.
I want to ask Kimberly a question. I just got finished doing the intensive 14 modules and went through the whole process of becoming a peer specialist, and with what my work that I've done all my life with kids and groups and everything. Do you feel that your training and the modules and all that was helpful in dealing with the participants in the different programs? And yeah, I'll let you take it from there. You're muted.
No
Okay.
problem. So my stories, my journey with working as a peer is a bit different than most peers, because technically most peers, when they go into the peer work, they will then sometimes venture into social work. For me, it was flipped. I have a background in social work, and in my internship, I learned of the peer program, and then I ventured into peer work afterwards. So I was able to gain my master's, but afterwards I started to delve into peer work. And so I kind of have like a combined experience with how I work with participants or work with like different clients, I would say, depending on where we are in the setting, right? The terminology used. initially, I do think that the modules do help get an understanding of how we support others outside, especially because I had that background of social work. It helped me understand how to support others without a therapy mindset and without I want to support you by setting goals. I want to support you. It helped a set a mutuality. I know that's one of the core principles is mutuality, and that's one of my favorite principles because it allows there to be a sense of I see you, you see me, and we're working together to go through this journey together. Versus like on a more medical concept, that wouldn't be exactly what's happening because of what in therapy they use conscious transference and transference, but in peer work we're allowed to self-disclose more often, right? As more as far as it goes for assisting the and supporting the participant that you're working with. So I will say learning the background knowledge of peer work, which is part of the modules that we and congratulations by the way, part of the education that we gain. I think that really allowed me to understand what peer work is and understand that there's a difference between peer work and the medical system, right? Because there's the history of the consumers and everything else that goes into it, the different names that peers went through, so that they can have a sense of identity outside of the medical system or just outside of any sorts of systemic or social justice oppression, right? So I do think it has helped me. One critique I would add is that I think with different programs, it's not explained enough that there might be a different expectation of you as a peer when you're working with other participants depending on what program you're in, because I used to support other peers in a crisis respite experience, and that was different than On Track New York because I was working with adults, one, and then for another reason is because as a peer with On Track New York, they encourage us to really apply this person-centered model, right? So I don't really apply my suggestions to the participants I work with. I allow them to lead me, and then we going to navigate how they want our conversations or just my support to go. Versus at the other setting where I could offer more suggestions because as a peer, like we were in that more mutuality aspect, right? So I do think that that's one critique I have of the modules is understanding how different settings as a peer in your role can affect your understanding of what you can do as a peer. I hope that answers your question. It was long-winded.
Absolutely. Thank you. We'll talk some more. We'll talk some more.
No problem.
David. You're muted, David.
David, you're muted.
Lee or Liz, I think you can
Thank you.
unmute him. Oh,
Thank you.
sorry.
Dr. Frishberg, a question. In the event that a person is nearing the age 40 and you don't think that he or she is, quote, ready, are there any other alternatives?
Ready as in ready to participate in treatment?
No, to be on his own or her own without support.
Oh, so we don't graduate people just because they've turned 40. We don't there's no like time limit. There have been people who have decided, they're ready to be without treatment entirely or to have like a different treatment setting. But that's a decision that they've made or have made with their treatment teams. We don't require any kind of exit timeline. So yeah, there's no worries there. We would continue treating people as long. The only thing that I would say is as we continue to have Boost available for hopefully many years to come, that I could envision is perhaps as a person ages, potentially needing other, having other aging related needs that might not be fulfilled in our program down the line. And we do, Zucker has a geriatric program that would maybe be a better fit at a certain point, but we're still quite a few years off from any of our participants being of that age.
Thank you.
How do we
Any-
refer people to you? Do you, as a group, prefer that people enter? Because a lot of our interactions pre this meeting were directed towards Sway, to Nicole, I suppose, but that's just something I always wondered. You know, we'll call Sue Fitzgerald, we'll call different people when we have somebody we'd like to at least be referred to your programs. And I do have to say that very likely gave the mark. I love the ETP program, and I thought it was like amazing. It just, I'm so sad when it ended. I cried. But anyway, so do we contact you guys directly if we're, you know, because obviously we speak to people every day of the week. So, you know, we know somebody's specific appropriate for Boost or whatever. Do we refer them right to you, or what's your process?
Yeah, that slide has, you know, different contact info for each
Oh,
program.
you're right. I'll be share
It's
that.
so that's also that's one way to do it. To be fair, you know, we work closely with one another, and so Nicole is always a good first person. Even if, you know, even if it ends up with Boost, she'll make sure that I, you know, that I get to that the information gets to me. But yeah, you can reach out. We've, you know, each program has its own contact. So if you think that you've got somebody for one program specifically, you can reach out to those different contact points. But if you're ever not sure, we will work it out amongst ourselves and kind of figure out, okay, I think this person maybe is a better fit for Sway or ETP versus Boost.
Okay.
I have one more question. I could wait. I'm sorry. I'm going to stop the share because I can't see hands. Did anybody else have another question? Can somebody come to one of your groups just for medication management or one singular thing, or really the design of your program is the entire program?
Yeah, that's probably going to depend on the program a little bit. From well, I guess since I'm already talking, I'll share about Boost. So Boost, for Boost, essentially, you know, each service is kind of up to, you know, which services you participate in are sort of up to the person and depend on the treatment needs. The one thing that I would say about that is that the way our clinic is structured, it requires regular visits with a psychiatric provider. So even if you're not taking medications, even if your whole purpose for coming to the program is to participate in group, let's say, you still have to meet at least every, you know, at the absolute minimum, at least every 90 days with a psychiatrist or psychiatric NP. And that's just honestly, that's just a structural thing. It's just sort of the way our program is designed to keep a chart open. That's sort of the required participation, but we don't require that people are taking medications. So even if you're meeting with a psychiatrist, you can just come check in and then, you know, go to your weekly group if that's the main thing you're getting out of the program.
Yeah, and I'll just add, we have the same kind of principle of shared decision making. You can choose what services you think are going to help you the most. We might recommend things, but you're also the expert on what kind of help you think will work for you best, and or what makes you feel like you're best. And we inform people that we are required to do an intake, you know, and I think that's a good thing, right? We want to be able to see you and meet you in person. And similar to what Nate said here, you have to at least be seen for a med management visit every 3 months. But that doesn't have to be exclusively about medications. You're allowed to say no to that. You can talk about other health issues. You could just do a check-in. And you can choose the services that you want from our team.
Oh, Gail, you have your hand up, Gail. You're muted.
Well, okay. Do most of your participants live at home or live independently And if they do live at home, what facilitates them living in a more independent environment? What is the transition for that?
I guess I could talk about with ETP. I would say most of our participants are probably living at home with family or might be going to their dorms because we have a lot of young folks who are in college. I would say specifically maybe for our age range, what might be it's the I don't think there's anything getting in the way of living on their own. I think it's kind of the normal age to still be at home. So I think we do have a few that that might be a little bit towards closer to 35 and they're starting to leave the house, but to make the answer more concise, most of our people are living at home with their parents and nothing really getting in the way, just kind of that normal
But adding to that, do you assist in the transition from living with family to being an independent person living on their own? Do you help facilitate that?
Yeah, one of the things that I think is probably true for the other programs is sometimes in addition to typical therapy, we might do what we call like care management, right? And this might be like what basic resources does the family or young person not have that we can help get to? So maybe it's connections to supported housing or doing SCOA applications. And that's almost an equally important intervention that we provide is just what kinds of wraparound supports and resources that are offered in the state we can help get them access to. In Sway, because we're 12 to 25, like a huge proportion of our census lives at home because truly they're minors. But it isn't out of our scope to be thinking about that and partnering with the team to think about, what are the independent housing goals if that's what the young person wants. And then within Northwell, there's also some kind of other programs that maybe when a person is headed towards graduation, we might get them connected to maintain that. So like Health Home is a service where some programs can refer to kind of continue the care management needs on a more ongoing basis, if that's food access or help with bills. But largely it's part of our role as clinicians is to also do care management and address those basic needs. Does that
Okay.
answer your question or?
Yeah, thank you.
I would just also add sort of specifically in terms of boost, since our population's a little older, and many are really working towards or have already taken steps towards living more independently. Those last resources that Elaina mentioned, health home services, and we really try to kind of build partnerships with other programs that really help to kind of prop folks up and support them in these different aspects of living independently. The other thing that I mentioned, we have a team member whose title is recovery advocate, and one of the things that they've been working on has been building like a library of kind of online resources for independent living. So just a lot of sort of like how-to guides, like some helpful things. I sort of think of it like adulting 101, right? The stuff that maybe like you get shoved out of the house at some point and you start to figure it out. That might come a little bit harder for folks who, that transition's not as seamless. So we're putting together like a library of, okay, like here's how you like keep your space pretty clean, and here's how you like navigate a conversation with a landlord here. So some sort of tips and tricks that we're putting together, actually really hoping to kind of have that go live pretty soon. We'll be thinking about ways to kind of broadcast that out to more folks. So stay tuned. We may reach back out and share some of that information.
No,
Wonderful. That is so great.
I have to ask, how familiar are all of you? Elaine, you said that you were familiar with NAMI from NAMI, Nebraska. But Kristen and Nathan, how often, and Kimberly, how often do you recommend a caregiver participate in family to family, or a peer participate in our Unites group on Monday nights? That's at Zucker. Are you guys familiar?
Probably minimum once a week, and I have many participants who are very, very connected to NAMI.
Oh,
Agreed.
that's great.
I have recommended joining the NAMI peer group as well, because I am familiar with one of the peer specialists that runs the Friday, I believe, the Friday group, and I've also been joined the Friday group once. So I did a NAMI NYC as well. So I do mention it, especially if there's concepts around grieving. A lot I'll mention like NAMI's grieving groups. So I can do better. I can say that, but but it
Kimberly,
has,
come back. I'm there on Friday. Come back. Come back.
Yeah, John does Fridays. Yeah.
oh, that's amazing, John. Okay, so I'll have to come back again.
Mhm.
Thank you.
I just say that because I mean, sometimes I feel like it's yesterday because, life flies by. But, I remember the ETP program, and that parent group, I of course would go, you guys all know me well enough to know I would go to the free support groups that were provided for parents, but not everybody did. And so I also went to NAMI because I was so confused, which I think is common to the ETP parent. Tremendous confusion as to what's going on in their loved one's life. So yeah, so that was like, that's our prime candidate, Kristen. Our people in your program, and same thing with you, Elaina. Those are our prime, and we want more of your people, Elaina. We try so hard to get people into basics, which David and Gail are a proponent of. We have a hard time, and we've worked with Vera Fiora a lot of convincing parents of young kids, not convincing, but introducing our programs to them. It's hard. We gotta,
I agree. I actually, I wanted to reach out to invite some of our families and participants to come to this meeting, but then I had some worries about like if I didn't want them to feel pressured because I was there. So, I did talk about this group specifically with some new families that I'm working with, and I highlight for me, like, it's so much different hearing from someone I know what it's like versus that must be hard, right? That's something I
Yes.
actually heard from a peer specialist. Doesn't that hit? Um, and it really is, I think there are many feelings we grapple with alone in this, and having this sense that I'm not alone and that there are other people who know what I'm going through and know the frustrations of the system, and I'm seeing lots of head nods. And I think that just speaks such power, right? And so I often say like this is something you're going to get beyond our team, and it's going to give back to you, like going to these different groups that are offered. I talk about the Black Minds Matter groups that NAMI offers with some of my families, because I'm like, you need this space. Or some of the peer supports that are offered too. I know there's also like music connections within NAMI and spiritual groups, and it's really just like the beauty of what you do is that you have such a huge community, right? That's like hungry for this. And so, we're receptive to receiving resources. We can include it in, maybe we can on our team include it in our intake packet, like our intake folders that we send home. But I also know that, many of these families live very, very busy lives, and it's always hard, but we will continue to spread the word because I think we all agree it's such a wonderful resource you provide to the community.
Thank you, Elaina. Thank you so much. This is so important, and I'm so glad we got to do this. And thank you for letting us record it for other families. And certainly you can tell your families who might benefit to go on our website and look it up once it's posted. Um, I I am just so happy that it finally happened because we've been waiting a long time to get this done. And I hope we can do it again. in the future, because there are so many more matters to discuss and so much going on in research, and we need to know more to help our community. And you have been the most amazing resource. Thank you so much. Uh, if we were in person, you'd be getting a certificate. But since so we talked about that, we figured that people who come and present to our groups really should get some recognition. So perhaps we'll mail something out to you, but I can't thank you enough for your time and for your concern and for your cooperation with NAMI. Zucker Hillside is an amazing partner with us, from Anita Mancini and Susan Fitzgerald, Mary Beth McManus, Carmine, who's so involved with, well, he's retired, but he'll always be there for us. And Olga, just so many people. I can't name them all, but welcome to the family, and thank you for being part of the family and for spending this evening with us. It has been eye-opening. Thank you.
Thank you so much.
Thank you. Yeah.
Thank you.
It's
Happy
been
to-
a pleasure to have you. Just a pleasure. Thank you again.
Thank you.
We should thank you, right? You all are organizing this, doing this voluntarily, allowing us to come and talk, being really honest about your questions or feelings. Like, actually, it's a pleasure to just not talk to avoid, right? And I just thank you for caring so much, right? I think there's nothing else I can really say beyond that.
Well, check our
Absolutely.
website and come to our meetings from now on. We'd love to have you.
All right. Thank you.
All right.
Okay.
Thank you so
Good night,
much.
everybody.
Thank you. Good night.
Good night.